Well, it is 12 o'clock. Is it all right if I kick this off for everyone? Dr. Hashi, good to have you. Welcome everyone to this special encore presentation, if you will, of IPE Grand Rounds. This is had been a fixture of the College of Health in terms of at least, well, a few times a semester we would get together to discuss a topic of interest from an interprofessional standpoint. My name is Chris Owens. I'm the Associate Vice President for Health Sciences, and I welcome you all to today's special topic, Vaccine Update Rapid Fire. Our guest speaker today is Dr. Dave Hashi, a professor in the Department of Family Medicine here at Idaho State University. You're also the director, Dr. Hashi is, of the Ryan White HIV program and a partner of the ICIPD. And his interest in vaccines and preventable diseases goes back some 25 years in his teaching, his clinical practice, and his scholarship on local, regional, as well as a global level. We're delighted to have you back, Dr. Hashi, to speak to us today. And I'm just going to turn the time over to you. Thank you so much.
Thank you. You bet. Thank you. And can you see my screen share real quick? Okay, perfect. Not that there's been a whole lot of updates in regards to vaccines lately. I know this is a boring topic, but we're going to try to make the best out of it and hit some highlights, hit some moving targets, have some good conversation. I think just as a quick point of reference, for any questions that may come up, thoughts, topics of conversation, I like to keep these as open as we can. So just put your thoughts in the chat thread. We'll get through everything, I think, in a reasonable time, and then leave the last bit to have some collegial conversation. And I think what we're going to hit the highlights on today, as there have been some changes, is we'll talk about influenza as we are kind of hitting that front step of flu season. We'll talk about some of the changes with pneumonia. RSV has been some movement in the last bit. COVID is always a hot topic, and with everything that's happened in the last 4 or 5 days, hope to bring you the most accurate, up-to-date information, but there's still a lot of clarity, I think, that we need to see. Hepatitis B vaccine we'll address. We'll talk a little bit about the measles outbreak and some recommendations that came out of last week's meeting. And then we'll talk a little bit about pertussis. So a few things to set the stage. Resources. This is can be a challenging time to find good, accurate, reliable data in regards to vaccines. There's a lot of information out there. And I still, at this point, am utilizing a majority of the information from the Centers for Disease Control at cdc.gov. And all my slides, I believe, are pretty much referenced out of there. But there are other organizations that are beginning to step forward in light of the changing landscape in regards to public health and preventable disease. And we'll talk a little bit about some of the recommendations from other organizations, especially AAP and ACOG. And there's also other newer coalitions forming to address their own regional public health needs and issues. And there have been a couple formed in the last, few weeks. You'll see the West Coast Health Alliance and the Northeast Public Health Collaborative. And we're likely to see more of these form. States are also taking initial initiatives individually as well. And all my information is as updated as it possibly could be. As of this morning, things may have changed in the last hour or two, and I may have missed something. So if I did, please feel free to point it out to me. Okay, we're going to dive into hopefully the least controversial of anything, and that's influenza, right? I mean, we've been talking about influenza for forever and a day, and things haven't changed a whole lot in the last 10, 15 years. What's, I think, important to point out, again, is the disease burden that we see from influenza. regards just the number of illnesses, the lost work, the annual visits, the hospitalizations and deaths that we see annually from influenza. And this is a disease of the age spectrum, and most recent updated information is right around 270 pediatric deaths that happened in the last flu year. And those were in mostly healthy children. And so again, I think it is important to point out that the flu vaccine is not just for those at risk, but for everybody. And that is echoed in the current recommendation from the CDC, which is if you have a pulse and you're over 6 months of age with no contraindication, get a vaccine. And when we look at the vaccine efficacy and we look at the data, it is quite effective in reducing outpatient visits for both children and adults. And when we look at reduction in hospitalizations, it's about 50 and 70% effective for adults and children. So it is I still think a very effective vaccine, and one that has fairly low vaccine hesitancy and quite a bit of vaccine uptake. So I think a few things to highlight for this year are making sure when you're vaccinated or you're recommending vaccines for your patients that you get the appropriate dose based on age. And most of the time we see this in older adults, making sure they have access to the high dose vaccine. And that is proven to be a bit more effective in individuals who may not have as robust of an immune response, or at least in the aging population. There's also an opportunity with FluMist. This is the only live influenza vaccine. This is the nasal spray, and it has been utilized in children, I believe 2 years and above, up to ages 49 in non-pregnant individuals. We just avoid live vaccines in individuals who are pregnant. But the key takeaway with this is it's now available for at-home use. This either had to be administered in a medical provider's office or at the pharmacy. And for you or patients that want the convenience of getting the vaccine and not having it as an injection, you can go to flumist.com and follow the prompts and navigate getting that delivered at home use. Individuals who are pregnant, I mentioned you want the inactivated influenza vaccine, and that 3 is for the trivalent. Some years you'll see a 4 for quadvalent. Right now, everything recommended is just trivalent or the recombinant influenza vaccine. And the one thing that came about that I've seen has been fairly recent is the egg allergy. Now, a lot of the inactivated vaccines are cultured in eggs, and there was a history that if you had an allergy to eggs, you don't get the vaccine. Well, there has been new data out that for those individuals with egg allergies, there's no concerns and get whatever you want. And we're beginning to hit that window of October to November, making sure it's right in that sweet spot to maintain good antibody titers. And I think the other thing that we need to begin examining a little bit more is the secondary impacts of influenza or vaccines, the benefit outside of the reduction in the disease. And when we look at some recent data that was published, is that flu vaccines can reduce rates of MIs by 25%. And so we would have a number needed to vaccinate essentially of 56. So for every 56 patients you vaccinate, you reduce the you reduce 1 MI. And part of that is again, this isn't necessarily groundbreaking. We've seen this in years in HIV, that persons living with HIV have higher rates of cardiovascular events. And a lot of this virally mediated is through increase in inflammation and inflammatory processes. But it is nice to begin to see more data emerging in the vaccine realm with this. Okay, so that's influenza. Things I think are pretty straightforward, but maybe a couple pieces of information you are unfamiliar with. And if you have questions, please put them in the chat thread and we'll circle back to them at the end. Now, Pneumonia has been a bit of a moving target the last few years. As we're all aware, pneumococcus is responsible for, septic disease, respiratory disease, otitis, lots of different processes. And anyone can get it, but there are those that have pre-existing lung disease, heart disease, that may have other complications if they become infected. And so looking at the current 2025 recommendations, we still have the pediatric series. This is a 4-dose series of either what is referred to as the pneumococcal conjugate vaccine, PCV15 or 20. Those are the two right now that are approved in pediatrics. They are fairly new in the last few years, so you may have had some kids receive PCV 13. But those age 5 through 49 with certain risk conditions should also receive the vaccine. And this is where it gets a little bit confusing. Are those older than now 15? It used to be that 65 and above. This has dropped down to 50. And essentially, it's one and done if you use PCV 20 or PCV 21. And the numbers just indicate and correlate to the number of serotypes of pneumococcus the vaccine covers. And as the newer vaccines have been developed with a broader serotype coverage, and this protein-based vaccine has a more durable action, right now the recommendations are just this one and done. Where things get a little confusing are for people that may have had previous vaccines. Maybe they had the old polysaccharide vaccine. So kind of what do we do? So I just kind of wanted to walk through a little bit of this as some of this has created some confusion. So if we just talk about those 15 above, if you've never been vaccinated, you get one of the PCV 20 or 21, like I was just saying, and you're good for life. If somebody has previously received 13 or the polysaccharide vaccine, let's say they were, 40 and they had history of asthma and they received it. Now they hit 50, give them the PCV 20 or 21, and then they're good for life. For those over 65, at this point, a majority of people have gone through their series, maybe with the earlier recommendations. And if that's the case, as long as it's been 5 years since their previous vaccine, they can get the 20 or 21 valent vaccine, and again, good for life. And given the high ceiling of safety of these vaccines, individuals who can't remember, don't have documentation, having shared decision-making, and generally vaccinating is going to be a good decision for them, especially if they can't remember. All right, RSV vaccine. And what we're talking about here is not just the vaccine, but we're also talking about monoclonal antibodies. And respiratory syncytial virus has sort of come to the forefront of the press in the last several years when they talk about, I believe they call it like triple demics, influenza, COVID, and RSV. So this one has emerged a little bit, partly in context of, especially in older individuals and very young individuals, the chances of leading to hospitalization is fairly high. And so the CDC does recommend immunizations to protect infants, some young children, and older individuals at risk. And because this is, again, a respiratory disease, we're trying to prioritize and highlight individuals that may have pre-existing lung disease. So when we think about these recommendations, we need to think about them sort of in two pools. We think about them in our older population, and then those in the younger population. And the current FDA recommendations are for anybody 75 and older to receive a vaccine, or those 50 to 74 at increased risk of severe RSV. And there are 3 vaccines available. For the last several years, GSK's and Pfizer's have been available. Moderna just released a new one that's an mRNA-based vaccine. And when we talk about timing of vaccine, this is generally the time to do it, late summer, early fall, before that RSV season hits, which is typically through the winter months. The other two populations are individuals who are pregnant at 32 to 36 weeks of gestation in that window of September through January. And I have a visual of this that helps clarify this in another slide or two. But the only vaccine that's approved in this population is the Abrysvo vaccine. So those individuals would get one dose, and it's been shown as the mother passes those antibodies on to the newborn, you can get a reduction in hospitalization of nearly 70% in those first 3 months. And if unable to vaccinate, then we go over to the other side where we utilize these monoclonal antibodies. So if the child's born between October and March, the mother did not receive the vaccine or is unknown, you give one dose of the nirsevimab or clesrovimab and within 1 week of birth. And again, it's very similar to kids born April to September. But again, with those, you want to do that before RSV season. These have been, again, very highly effective in reducing hospitalizations by nearly 80%. So even more effective than the vaccine for the mother. And the one of the most recent or the summer recommendations from the Advisory Committee on Immunization Practices recommended adding the second monoclonal antibody in. So there's now a couple options available. And this again is the sort of the visual, if you will. Infants and children, you have the two options of the monoclonals between October and March. And individuals who are pregnant between September and January at 32 to 36 weeks gestation get the Abrysvo, and your older individuals, and this is the age sort of 50 to 64. I think that's maybe a state issued age range. To hit some safety concerns with this vaccine, with both GSK's and Pfizer's platforms, there has been an increased signaling for Guillain-Barré syndrome, usually within 8 weeks of vaccination. They have seen that, and they have not seen that signal with the new mRNA-based platform for Moderna. And again, if that's a concern for patients, just try and find a pharmacy that has the most appropriate vaccine that you're looking for. What we also don't know is what the number of doses are. Current data is suggesting that there's coverage for about 3 years. So right now it's not an annual vaccine. We don't know when the most appropriate window is going to be, but that data is emerging. And finally, it is safe to co-administer with other vaccines. The time of year, people are getting their flu, their COVID, and their RSV, that's fine. Some people also do for their pneumococcal. That's generally fine as well. Some people like to space their vaccines out, given the sometimes the local reactions. People don't like navigating multiple of those. Now, the data on individuals less than 50, some people do try to go into their provider, into their pharmacy and say, I want an RSV vaccine, even though I'm 45. Right now, those aren't generally being covered and are not being recommended, partly because we don't have good data on efficacy or safety. And so right now there's more cost effectiveness analyses going on, also looking at the safety signals. So right now the CDC is providing a little bit of caution in this group until more data is available. Okay, now into COVID-19. And this has been a huge moving target the last several months, and more so even over the last week. So hopefully I'm going to do this justice and decipher and whittle down a lot of the noise and static so that you can walk away knowing what the most current recommendations are and the appropriate application. That being said, I like to step back and remind everybody, because this even gets lost within the realm of healthcare providers, that the recommendation of the vaccine is not so that people do not get infected. It's that when they get infected, that it reduces serious health outcomes. And this is true for pretty much all vaccines. And I think we lose sight of that. It doesn't provide a bubble around us that prevents us from becoming infected. It provides us with antibodies should we see the antigen or the virus or the bacteria that we're able to mount an immune response and reduce the likelihood of severity. And the clinical trials and real world studies consistently show vaccination provides sustained, reliable protection against severe illness, death, even with the emergence of new vaccines. So let's take a look at a few things and go back into our time machine from a few years ago. I don't think we should lose sight of the number of deaths that we were seeing early on in the pandemic in 2021. But every year those have come down, and we have seen different sort of bimodal rates of infections, which also correlates with death. But we have seen fewer deaths over the last several years. But when we look at it on an aggregate scale, we're still, 1.2 million plus individuals have died in the US from COVID. And looking at the rate of infections, this just sort of stacks last 3 years of data of infections. And excuse me, we still are seeing sort of this bimodal late summer, midwinter sort of pattern with COVID. And so it's not falling into this necessarily like influenza, like it's going to be a single year. As we're learning more, I think that is translating into better recommendations and better guidance. But that being said, I think the important thing to recognize here is that we are still seeing a reduction in cases. A big part of this has been with the application and use of vaccines. Also, individuals who are infected will mount their own immune response. And vaccine or titers for protection, whether it's from vaccines or infection, generally last about 4 to 6 months. And so if somebody has had a recent infection, we generally recommend waiting 3 to 4 months before receiving a vaccine, should they be a candidate. So where does the confusion sort of arise? Lately, it's been on multiple different levels. And I just wanted to go through some of these with you. So the first is the FDA. So the Food and Drug Administration is responsible for ensuring all vaccines are safe and effective for intended use. And in the past, the vaccines have been approved with a broad expanded use authorization, now to a more restricted age range. So it's the FDA that will approve a drug or vaccines indication for age. And then when we look at the ACIP, which, for decades has been one of the most boring committees on the face of the planet, but the Advisory Committee on Immunization Practices has got a lot of press lately, as this is the group that provides advice and guidance to what we think mostly of the CDC, but also other entities at the federal level. And they are the ones responsible for evaluating data and making recommendations on vaccine preventable disease. And it is ultimately the CDC's response to provide the recommendations or enact the recommendations of ACIP. And for years, it's mostly been a rubber stamp. But again, over the last 6 months or so, there's been more discrepancy in regards to the recommendations that come through to what's being approved, because it's ultimately up to the director of the CDC to accept or reject recommendations. And also when we look at the FDA's approval of these vaccines, and we have 3 vaccines, none of these are really should not be new information. But just to recap, a lot of them have been recommended for people over 65 and those at high risk, including Moderna and Pfizer's, which is both mRNA-based platform, and then the Novavax platform, which is your more traditional protein-based vaccine. And you can see the different age ranges and recommendations, but Moderna's vaccine is for individuals 6 months and older. Pfizer's is down to age 5, and Novavax is down to age 12. And you'll also see this term high risk. And the CDC does provide a sort of a list of what's indicated as high risk, including a lot of diseases that should you get infected, you may have, again, sort of a flare or an exacerbation. Or maybe you don't have the immune status, maybe you're immune suppressed, you have HIV, you had a transplant. So a lot of individuals and a lot of high-risk conditions exist. And I encourage you to be aware of those if you are making recommendations or talking to patients about vaccines. So what are the current recommendations? Well, the current recommendations are still, because they have not been accepted by the CDC, are still based on essentially last year's recommendations as far as I can tell. But what was voted on last Friday was that all COVID-19 vaccines should be, the use of them should be determined by individual decision-making. This is for everybody 6 months and above. Again, if you asked me a week ago what I would have said, well, everybody 65 and above, and those less than with high risk factors is essentially, who I would be recommending the vaccine. At this point, it's now all individuals 6 months and older should have individual or shared decision making. Now, how is this going to play out? What is individual decision making? A lot of times it's conversation between patient and provider, patient and pharmacist at the level of the pharmacy, because remember, not every patient has a medical provider. And so any way we can reduce the barriers to getting patients who need the vaccine or want the vaccine vaccinated, that's the route. And so I think at this point, probably in the next couple of weeks, you're going to hear a lot of conversation about individual decision-making, shared decision-making. But again, I think when we look at the evidence to try to decloud or declutter some of this, the evidence of efficacy of these vaccines, especially in those at most vulnerable, ages 65 and above, is very clear. And those patients should still be prioritized. And then anybody under that wanting to be vaccinated, that is also, again, that individual decision-making that should be supported. And one of the things that also has come up a lot over the last couple of weeks is needing a prescription. Depending on your state, you might need a prescription. In Idaho, we did not. You could walk into a pharmacy and request a vaccine and receive it without a prescription from your provider. And last week, one of the votes by the Advisory Committee on Immunization Practices was to have no prescription requirement for COVID-19 vaccines. Again, this still needs to be approved and enacted, so things are still playing out a little bit. But really what this does is this ensures that vaccines remain available without a prescription and reduce the barriers to getting one. So again, I think this was a very positive vote from ACIP last week. Then the other question comes up: is my insurance going to pay for it? This is always one, when you get to the pharmacy or you get a bill from the clinic, is my insurance paying for it? And over the last couple of weeks, the American Health Insurance Plans, AHIP, did come out with a statement basically saying that health plans will continue to cover ACIP recommended immunizations that were recommended as of September 1st, 2025, including updated formulations of COVID with no cost sharing for patients through the end of 2026. So this kind of says to me, it doesn't matter what the new CDC guidelines are. Health insurances are going to pay for vaccines up to the end of 2026. Now, things may move, targets may change, but at this point, at least the insurance companies are stepping forward, saying they're going to cover that. This has also been echoed by Kaiser Permanente, which is one of the largest insurers, and that they're paying for and covering vaccines from ages 6 months and above. The other two organizations that have stepped forward because there was a removal in recommendations of for individuals who are pregnant and children, that the American College of Obstetrics and Gynecologists are still recommending that individuals who are pregnant receive a vaccine, given the safety and efficacy, and that all clinicians should provide that strong recommendation to pregnant and lactating patients. And then as far as the pediatrics, that the American Academy of Pediatrics has come out saying that any parent essentially who wants their child to have a vaccine should receive one. So really that last bullet point is the takeaway. Certainly high risk groups, prioritizing individuals, but any parent who wants their child to have one should receive one. And again, based on appropriate age of the vaccine's indication. And then concerns come up of vaccine adverse effects. And if you or your patients ever feel that there is an adverse effects, there is the VAERS system, Vaccine Adverse Event Reporting System. And that's how the CDC tracks adverse, and the FDA tracks adverse events and looks for signaling that may not have been picked up in clinical trials. But what is common, especially with COVID vaccines, is you feel like crap. Any vaccine that is mounting an immune response generally has some chills, fevers, headaches. Those things are very common. There may also be pain or soreness at the injection site. And the concern of myocarditis and pericarditis have been brought up since the early outset of the vaccines. And it has been seen mostly in young adolescent males within 7 days of their second COVID vaccine. That's when it was seen the most. But what is also important is to recognize that the incidence of myocarditis is 7 times higher in persons infected with SARS-CoV-2 than those who receive the vaccine. So for individuals who have concerns of not wanting to receive the vaccine because of the risk of these adverse effects, I think it's also important to educate them that should they choose not to get vaccinated, they are also at risk for these conditions and at a greater risk. So what does all this mean? All these recommendations and moving targets. So the first thing is recommendations have not been adopted, and this is going to continue to have a lack of clarity at the patient level in regards to insurance companies catching up, pharmacy policies and procedures catching up on who they can and can't vaccinate. But I think given that the vaccine now, the proposed recommendations is shared decision-making, it's fair to say that anyone wishing to have a vaccine for COVID should be able to receive one, should be able to have it paid for by their insurance. And I think as a community, we also need to recognize that we need to have patients at highest risk prioritized. There should be no need for a prescription. This may be a little bit delayed in some states. Insurance should also cover it, probably until 2026, and that there are 3 vaccine options. And as far as the options of the protein-based, the Novavax one, that one I have not seen yet in the shelves of pharmacies, but it should be available shortly. And the Novavax vaccine tends to have less reactogenicity. It's not mRNA based, and there's some data to suggest it may have a little bit longer antibody titer coverage. That one may be appealing for patients that still have some vaccine hesitancy with the mRNA-based platforms, but would still like to be vaccinated for COVID. Okay, so that was a lot on COVID. So if you have questions, again, please put them in the chat thread, or we'll circle back to them here in the next little bit. Hepatitis B. The good thing about hepatitis B is that the vaccine recommendations have become essentially universal. This was on the docket to be voted on last week at ACIP to talk about this birth dose that I'll get to in just a second. But the one recommendation that was voted on was to ensure that all pregnant women be tested for hepatitis B. I think it's also important to recognize that not all pregnant women have access to health care, see a provider, and not all providers that see patients who are pregnant are doing this. So although this is an important step, it's not the end all be all. And so the first dose of hepatitis B vaccine that is recommended for infants is a birth dose. So I still remember the birth of my first child, the chaos that was everything in the room. And I want to say before that umbilical cord was cut, they had pretty much the nurse was there with the vaccine and it was administered. And so at this point, the ACIP is looking for more data on safety and efficacy of birth dose. And so the vote has been to table this conversation about birth dose to a later meeting. So at this point, the birth dose CDC recommendation is still being recommended. Now, there may be stock issues with my second child. They didn't have vaccine in the hospital and needed to wait until the first visit to get that first dose. So essentially, Hep B vaccine is recommended for everybody. It is now universal. It's not based on risk factors. It's not if you're a man who has sex with men, or you have multiple sex partners, or you inject drugs. It is, again, for all kids, and it's been that way for a long time. But adults who are either non-immune or want the vaccine should receive it. And then those older than 60 with risk factors, those are the ones that probably more shared decision making. But again, there's that universal hepatitis B vaccine, and this is the child's schedule. Again, with doses at birth, 1 month, and then 6 months. There are a couple different vaccines available, some that combine Hep A and Hep B, so just be aware of those. And then the big change, I think, is, and I say big change, Heplisave B, it's an adjuvated hepatitis B vaccine. It generates a more robust immune response, and you only need 2 doses, 1 month apart. So for all of you in the healthcare setting that have students that need to be vaccinated, this is usually a surefire way to make sure you get your 2 in you, because a lot of times they start the series and they move and they're like, oh, I forgot about that 3rd dose. So Heplisave B is at most pharmacies that I've seen and is pretty standard, and is sort of beginning to make its way as a more prominent player in the hepatitis B dosing environment. And it's only for individuals 18 and above. This one has not been approved for children as of yet. All right, that's Hep B. Then let's chat about measles and the MMR vaccine and the MMRV vaccine, as that's gotten some, press. But I think looking back into our rearview mirror, how did we get to this point? What's going on? For those of us that have been practicing in healthcare for a number of years, know that measles was declared eliminated in the US in 2000. because of the high vaccine rates. But because targets have fallen below that 95% coverage, what we've seen is an increase in cases, and both globally as well as in the US. So this is US-based data, and you can see that back in 2024, we had some blips, but it wasn't until early 2025 that we had a big outbreak down in, started more so in Texas. So again, this is as of September 9th. There were close to 1,500 cases. The majority were in Texas. Believe, at least as from what I've seen today from the health and welfare, that there are 3 cases in Idaho. If somebody knows any other information, feel free to share that. But the important things about these cases that I think we need to highlight is, of the nearly 1,500 cases, the majority have been in individuals under 18 or 19 and under. And those who have contracted measles, the majority have been unvaccinated, and some of those are vaccine status unknown, but the majority unvaccinated. So the outcomes is, I think we also need to mention that there have been 3 confirmed deaths from measles, and these are vaccine preventable deaths. These are deaths that could be avoided. We have seen hospitalizations, and the majority of hospitalizations, again, have been in the younger individuals. So in looking at vaccine coverage, again, Idaho has the lowest vaccine rate in the country at under 80%. It's at 79%. And it's a matter of time, again, over the next, now with kids back in school, that we'll start seeing more cases. That's, again, I obviously don't have a crystal ball, but given the trends and patterns that we've seen from other states over the last 6 months, our public health officials, medical providers are on full alert of trying to identify and catch things early. So what are the recommendations? The recommendations really haven't changed. These are live vaccines. So measles, mumps, rubella, and varicella they're all live vaccines. And MMR has been traditionally given together for decades, 2-dose series. Once you hit 12 months, you get your first dose, and then you get your second dose between ages 4 to 6. And just as a note, there is no specific antiviral therapy that's FDA approved for measles. Medical care is generally supportive. There's been a lot of press about the use of vitamin A. This comes mostly from resource-limited settings in low-income countries. But vitamin A may be used under the supervision of a healthcare provider, but it does not prevent measles, and it's not a substitute for vaccination. And that is right from the CDC's website. So what are we going to be seeing for some changes here? The ACIP voted last Friday to separate the 4 vaccine combination of MMRV to just MMR, and then administer varicella at a separate time. And the data that they're citing from this and for this recommendation is that there have been higher rates of febrile seizures when the 4 vaccine combination is given compared to when it is separated. Again, these cases are extremely rare. Febrile seizures are common. Medical providers know how to navigate them, as long as we, again, navigate and educate parents. So again, that combination, we will see a separation in upcoming guidance, most likely. All right, the last couple, as we head into the home stretch, and then we'll open up to some questions, is Tdap, tetanus, diphtheria, and acellular pertussis, and really focused on acellular pertussis. But it's kind of like the Three Stooges. You can't talk about one without talking about the others, and they're all sort of linked together. So Chris knows Mo, Larry, and Curly, but this one doesn't have Shemps. I'm sorry, Chris. Okay, so why are we talking about pertussis? Again, we're talking about whooping cough. It is extremely contagious, and with decreasing vaccination rates, we have seen increasing case numbers of whooping cough. And unlike the cold, this cough can last for weeks. And the current CDC recommendations are for all children, infants, adolescents, and pregnant women. We'll get into the specific schedule here shortly. And a dose of vaccine for adults who didn't receive one either as an adolescent or adults. And the United States uses two types of combination vaccines. DTaP, which is the pediatric, it has the higher dose of diphtheria, and then what you'll see is Tdap. So this does get confusing. And some people will walk in saying, I just want my pertussis vaccine. Doesn't exist. You have to get it in combination with the other. And even the tetanus and diphtheria is really no longer or not readily available anymore. I have had patients that have walked in requesting that and not being able to access that through any wholesaler or manufacturer. Now, when we look at cases over the last 100 years of pertussis, again, we were looking at several 100,000 cases back in the 40s and 50s. Then we introduced the vaccine and saw a dramatic drop in cases. Then we had different formulations for adults. And then we can see over the last 10 years, the emergence in newer cases. And again, a lot of this is from failure to complete vaccinations or individuals who choose not to be vaccinated. This is the majority of cases that we're seeing it in. So for children, it is a 5-dose series, and it's hard sometimes to complete all 5 doses, even in individuals that attend all their well child visits. For adults, if they've completed their primary series and received at least one Tdap, generally recommend it every 10 years. And that's, again, the common one that we hear is I need my tetanus booster every 10 years. Well, you're kind of getting all 3 of them every 10 years. For individuals who are pregnant, it is recommended to receive 1 dose of Tdap during each pregnancy, generally in the early part of the gestational weeks, 27 through 36. So those are the recommendations in pregnancy. And then for older individuals who may be around children who don't have documentation, it's also recommended that they should receive it as well, because they can be a carrier and transmit it. So again, just something to keep in mind there. All right, then other vaccines that there haven't been a lot of movement on, but I just wanted to, again, sort of honorable mentions. HPV vaccine should be highlighted as a focus on cancer prevention for not only cervical cancer in women, but oropharyngeal cancers, rectal cancers, anal cancers. It is effective in reducing all of those. It's recommended to initiate the vaccines between ages 9 and 12. For individuals who start later, you typically will need more doses. There hasn't been any movement that I've seen in regards to Hep A, polio, rotavirus, varicella, and again, shingles. Nothing other than as a reminder, it's indicated for everybody ages 50 and older as a universal vaccine. Those who are under 50 who may be immunocompromised or may become immunocompromised. So somebody, let's say, who's 45, is diagnosed with cancer, is going to be undergoing chemotherapy. It's important to vaccinate prior to that. And then the other thing too, similar to the influenza vaccine, the shingles vaccine is showing a reduction in nearly 20% in MIs and strokes. So again, another secondary reason, if you're looking for a reason to to be vaccinated is the protection there. All right, so it was a bit of a whirlwind tour, and we, I think, got through everything, and I'm going to stop sharing my screen and open up for questions. I can have Chris distribute the PowerPoint, or Lisa is fine, or wherever. So, questions? Who's been receiving? I know this is always a quiet group, so I'll ask some questions. Who has been seeing questions from patients, from students, from colleagues, and what questions have you been receiving?
Hi, this is Kate MacDonald. Thanks for the
Hey,
great
Kate.
presentation. I think my personal question and questions that I've been hearing is mostly insurance coverages. I think people are wanting to get vaccinated and just worried that they might lose access to their insurance coverage. So that's a lot of what I hear.
What have you been suggesting or recommending to patients or people do?
To get it as soon as possible.
Right. So I think you're probably, right in the wheelhouse of everybody else. I think I've seen a lot of people come in to get the vaccine before a lot of these changes may take place, to sort of get in, under the wire. It does look like now that it should be continue to be covered. Some of the time that I spend in community pharmacies over the last month, since the last few weeks, since the new vaccines have been available, I have not seen a lot of barriers for patients with insurance, whether that's state Medicaid, Medicare, or private insurance. So the other option is to have patients call their insurer. For those of us ISU employees, you can get on Regents, you can get on the app, and you can look for things that are covered or not covered. But I have not tried to get it yet myself, so I don't have any feedback as to what ISU's insurance has done. Maybe somebody else has, I don't know. Thanks. Other questions, thoughts?
Another thought, if someone else doesn't have a question.
Yeah.
I worry
Please,
with all
Kate.
the confusion in different recommendations. Like, I mean, we saw from the map that Idaho has the lowest vaccination rates. I worry that this might be a little bit trickier in trying to make our recommendations with vaccines. So I'm wondering if anyone has any experience. I don't have a large pediatric population in my clinic currently, but curious if anyone has seen a larger shift or more dramatic shift in vaccine hesitancy recently. I know it's been going on for a while, but if they've noticed any changes recently.
Give people an opportunity to chime in. Not hearing any, Kate. What I can tell you. Oh, Chris, go ahead.
Well, and I wanted to kind of hear what you have to say on this, Dave, and especially since you kind of kicked all of this off with flu shot being the least controversial, best uptake there. Is that still holding true, or is it spilling back over into that? And what do we make of that trend?
So at least speaking to Idaho data and more Southeast, my conversations with pediatrician in a pediatric group is reflective of since COVID in 2020, there has been higher rates of vaccine hesitancy for more vaccines. Idaho also carries the highest rate of vaccine exemptions across the country at about 12%. And that's another thing that's been fairly hot in the conversation has been vaccine mandates. But Chris, I to your point, and I think you are correct. I think with kids, we have seen lower rates of vaccines, especially if we're talking influenza. But I don't have that data in front of me to support that, other than, again, observations from pediatric groups based on the number of vaccines that they give each year and how they have seen a change in the number of those vaccines. And also reflective of that is the number of cases of certain conditions that they see that they typically never see, such as chickenpox. That they still see cases of chickenpox every year, albeit less common. So. All right. Well, we got just a few minutes left. I'll stick around. I know people need to jump off, get to class, get to their 1 o'clocks. But again, I appreciate everybody's time. And if there are follow-up questions, let me know. And Lisa and Chris, I will push the presentation over to you guys and you can distribute as you see fit. Okay, thank you.